very well. I'm very well. I've just been showing people horrible pictures of squat. We are, yeah, we are, and I know I don't think I've shown you my pictures, have I? Of the photodynamic therapy I had, which basically my whole face just sloughed off. We're just going to turn the comments off, but if you want to ask a question, I'll still be able to see it. You, you are the very lovely Dr. Hiba Injibar, dermatologist on Harley Street and lover of all things skin, and somebody who looks after their skin very well and, unlike me, does not have a single piece of pigmentation anywhere from sun damage, despite growing up in a very, very hot country. So I take my hat off to you.
I hate the sun. I don't go in the sun. If I go, it's very briefly with SPF, high SPF, and then I quickly run away. So that has maintained good skin, no pigmentation, and, you know, so far, luckily, no cancer.
I, however, have been a recidivist sun lover who fails to learn from any experience that I had. You know, when I was growing up, obviously in Australia, we spend a lot of time out in the sun and on the beach and all of those sorts of things. And when I was growing up, there wasn't really much in the way of sunscreen until I was around about a teenager. And then it was very thick white zinc cream, and no one was going to wear that. I mean, especially not all over your body. And you know, no self-respecting teenager was going out with, you know, their face covered in zinc. So that just didn't work at all. So it was a recipe for disaster.
Yeah.
So there you go.
Yes. So now there's no excuse, because all the good sunscreens are formulated in a very transparent, invisible manner. Even the high SPF, even the mineral ones, are really very easy to apply. There are mist sunscreens that I recommend my patients get when they go on the beach, because you can spray it on kids even when they're running and jumping, and you don't even need to rub it. So it's just a mist like your deodorant. So now sunscreen has become way advanced, way easier to use, and there are no excuses not to wear it every day.
That's true. I often wonder actually about the spray-on ones though, because how do you know if you're actually getting a good coverage? I mean, you know, unless there's no wind and your child is going to stand perfectly still, how do you know if you're getting a good coverage? And also, what are you breathing in?
Yeah, that's true. I mean, of course, there are some aerosols that you're breathing, but I mean, for ease of use, if you keep them steady and then you spray them on, you can, you know, you can always double apply and triple apply. You can do like a full lather of cream before they go on the beach, and then maybe 2 hours later, you don't want to grease them, then you can spray it on. You know, you can mix and match sunscreens. It doesn't always have to be just stick to one.
No, that's true.
Yeah.
Yeah, and the reason why this is important, apart from anything else, is because this is Sun Cancer Awareness Month, or Skin Cancer Awareness Month, and we often associate death with melanoma, but not the other types of cancer, non-melanoma skin cancers. And I have a couple of statistics here, which are a little bit on the scary side. They estimate there are around about 250,000 cases of non-melanoma cancers in the UK every year. The majority are basal cell carcinomas, about 180,000 of them, and there are more than 1,000 deaths a year from them, and they're expecting that to significantly rise. So apparently the melanoma deaths are coming down, but they're thinking that the non-melanoma death rate will start to go up, because people don't really know what they've got and they're not looking at their skin.
My statistics are higher. So you did the UK ones. I don't know how accurate it is. I don't have them. But my statistics say 5.4 million basal cells and squamous cell carcinomas per year in the US. 80% of these are basal cell carcinoma. And in Australia, where you come from, 1.17 per 100, so 1.17% of people have skin cancer.
Yep.
So I think it's much higher than a quarter a million a year. You know, there's always the fact that they might not be reported, so that's why the incidence is reduced.
Yeah, actually, I wrote a story on for Health Education Australia a few weeks ago, actually on skin cancer in Australia. And by the time people reach 70, 2 out of 3 Australians will have some form of skin cancer, which is quite scary. And then, and you
It's
think here,
fun.
yeah, if you think here, now people are having more of their holidays abroad, and well, obviously during COVID they were, but generally more people are heading off to the south of France or Mallorca or wherever they go most summers, and doing what I did for years and frying themselves silly, and there is a price to be paid.
Yes. And I still get frantic when I see people on the beach or in sunny areas getting sunburned, or even in London when the sun comes up and you go to the park and you see them all burned. Now, every sunburn increases the risk of melanoma and skin cancer by a significant degree. And there's always a lag of 20 to 50 years from the time you get DNA damage from sun exposure to the time you develop cancer. So this is not happening instantaneously, but you need to protect yourself.
Yeah.
And American Academy of Dermatology recommends children under the age of 1 do not get out in the sun at all. And then older children, very strictly be protected, because that's the time when you're getting sun exposure and you're not careful. So then this leads to DNA damage.
Yeah, which is interesting here too, because the other thing that's popular here is sunbeds. Now, in Australia, they were banned decades ago. Victoria, I think, was the last state to actually get rid of them. But here, they're still incredibly popular, but they're very dangerous, aren't they?
They are extremely dangerous. And I have also more statistics. Using the tanning bed increases the risk of skin cancer by 59%. And the more you go in them, the higher the risk of skin cancer. And there are other risk factors for skin cancer. So the population is aging, so people are living longer, so that's why we're getting more skin cancers. We have higher rates of skin cancer detection. So doctors and people are more aware, so they get checking their skin earlier. So that's why we have higher rates of skin cancer. The ozone layer is getting depleted, so that makes it worse. And of course, the tanning beds. And the other risk factors would be low immunity. So, with cancers on the rise, other cancers, the patients are on chemotherapy and immunosuppressants, and that makes their skin's response to the ultraviolet even more risky. So it's like a vicious cycle. You get other cancers, you go on chemotherapy, you become more sensitive to the sun, and you develop more skin cancer.
Yeah, interesting. Shall we start with the sort of the first signs? And I'm taking my glasses off here so I can come and scare everybody by showing my face. At the moment, I don't know whether or not you can see it, but you can not just near that glasses bit. But see that little reddish spot there? That's an actinic keratosis. Now that is how
skin cancer.
I mean, you wouldn't even really notice it. And I think that this is one of the things that's quite interesting, isn't it? They're very. Describe what they are and how you'd know if you had them.
So we have 2 types. We're talking about non-melanoma skin cancers. We have 2 types, which is basal cell carcinomas and squamous cell carcinomas. Basal cell carcinomas are more prevalent. So 80% of non-melanoma skin cancers are basal cell carcinomas. And luckily, they are the less dangerous type. So they very, very, very rarely spread, and they very rarely kill people. The squamous cell carcinoma, so they both arise from different cells in the skin, and they're both due to mutations from sun, from UV, from ultraviolet. The squamous cell carcinoma starts off with actinic keratoses, which are rough patches. They just basically, patients come and say, I've had this rough spot, I can feel it, and it doesn't go away. Or they say a patch of dry skin. I have a photo here. I don't know if it's clear because I can't show you my computer screen, but I will show you this. So it's just like a little eczema or a little rough patch.
Yeah.
that does not disappear. They're very small. They can be one. They might have two. They might have five. They might have 100. So bald men with years and years of sun exposure have a lot on their scalp, and this is
I
called
I
actinic
have
keratosis.
I have a whole bunch of them here,
Yeah,
if you could sort of see. I mean, because yeah, I mean, a lot of these you wouldn't even pay an awful lot of attention to.
we
You,
don't
I
pay
mean,
attention to
yeah,
it.
exactly.
No.
And but yet they can turn very, very nasty.
Yeah, they do have a risk of changing into, skin cancer. It's not a very high risk, but they have to be treated because they're precancerous. And normally, how would we treat those? If it's like a few lesions, I freeze them. I do cryotherapy, same as I do for warts. If they are more, then they would do what you did, which is treating the whole area, the whole field, with applying chemotherapy creams, or sometimes even laser resurfacing will improve them and get rid of them.
I did photodynamic therapy, so
And
let me show
photodynamic.
you. This is if people
Yeah,
want to
that's
think, so I thought, okay, I had one or two little spots I thought that kept on coming back after I'd done lots of freezing of things and putting the Effudix on and all of that kind of stuff. So I thought, you know what, I just want this gone. I'll go and have photodynamic therapy. And I had no idea that basically my whole face was one giant actinic keratosis. And I can tell you now, as you can see, sorry, these are quite graphic and quite nasty photos. It was unbelievably painful. It was I call this my Klingon period, because literally for weeks I just looked like, something out of Star Trek. Not pleasant. There are better ways to spend your time than having a treatment like that. The only good thing about it was that nobody would sit next to me on the tube, so I had free seats
that's
around me.
good. Okay,
That was about the only good thing out of the whole thing.
you were
But
safe.
yeah, so it's yes, you're right. So basically, we can either freeze them off, we can use a cream that does pretty much what that does, but over a longer period of time, or the photodynamic therapy, and they're the three main things. And laser, yeah.
Yes, and lasers as well, or a chemical peel, even like a good medium depth chemical peel. Just to mention that if you apply that chemotherapy cream on skin that does not have actinic keratosis or does not have sun damage, they will not get the reaction you had. So that's explaining why you got it all over your face, because she has pre-malignant cells all over her face. And they were reacting with the chemotherapy or the whatever you were doing, the photodynamic therapy.
Yeah. Yep, it wasn't pleasant. Then the other thing that I've been using at the moment for the one on my nose is a solar rays, which is a diclofenac cream. Yeah.
Yeah, there are creams that can be used. So the most important thing is for people to detect them. If you have a rough spot, if you're fair-skinned, you have a rough spot that looks like a bit of eczema, it's not itchy, doesn't go away, you put moisturizer, it doesn't go away, it's a bit reddish, have it checked, because that can be actinic keratosis. And that changes into squamous cell carcinoma, which is the more serious one of the non-melanoma skin cancers.
Shall I show some pictures of those? Also,
Yeah.
what's the difference between a Bowen's disease and a squamous cell?
So, Bowen's disease is also pre-cancerous. That has not reached the stage of skin cancer yet. It's pre-cancerous, and it usually appears as a round red patch. Are you showing Bowen's disease?
Bowen's, yeah.
Yeah. So it's usually on the legs more commonly, on the arms, less so on the face. And it's a stage before skin cancer. So it's Bowen's disease is skin cancer that has not spread deep. It's squamous cell carcinoma that has not spread in depth. The actual cancer, when it happens, is an actual lump. So it's not flat anymore, it's raised, it's hard. It can have some whitish scales on it. It just feels hard, and it's keratinized. It has keratin in it, just like the material that forms our nails. I have a photo here.
Like these ones, yeah?
Yes, that's squamous cell carcinoma.
Yeah. Yep. And I've had one of these as well.
Okay.
I've had them all. Yep, you know me. I was apart from the melanoma so far, touch wood. Yes, had one of them removed from my leg last year.
So if you have one basal cell carcinoma or squamous cell carcinoma, you have higher than 50 to 60% chance of getting another one. So if you get them, or if you have cancer, it's always good to have regular checks, at least once a year. Do a full body skin exam to make sure you're not missing an early Bowen's disease or another one that's forming. And another common area for them to happen is the ear. So because the ear, we forget the ears, but they are sun exposed as well. So they can happen on sun. Do you want to show them a photo of a basal cell carcinoma? Then?
I shall. Where are we? Basal cells there. Before I do, I will show you. I'll show you mine. Why not? I was showing this before actually. I don't know if you can see it particularly well, but see that little moly thing there? That is a basal cell carcinoma. So that's got to come off next week, which will be fun because I've got my son's wedding in a few weeks. I'm going to end up looking like Scarface. But anyway, there you go. What can you do? See, they look quite benign, don't they? I mean, that just really looks like, pretty much nothing. This little one down here, you wouldn't really think that was anything extraordinary. You wouldn't think that was too. You just look at it and think it.
Red spot, a little bumpy. Some patients say I have an acne spot that keeps bleeding, and I've put salicylic acid on it. It does not go away, and it can grow very slowly over years. It's more common in men than women, but it's very, very common in women as well. It can happen anywhere on the skin, but more so on sun-exposed areas of the skin. It can even happen on the eyelids, and that's very complicated to remove, on the ears, on the scalp, on the hands. It's mostly sun-exposed areas of the skin.
And you kind of think, they just looking at those pictures there, they can be different colours too, because you always sort of, I always actually thought that they were sort of clear and shiny, because that's what mine have normally been like. Because I've had one off my face and two off my chest, and now this one. But I've had a friend actually, and we went to see a GP friend of ours actually for something entirely different, and she looked at her and she went, "I don't like that thing on your neck," and it was really dark, and I was really surprised that it ended up being a basal cell carcinoma.
They can be mistaken with melanoma because there's a subtype of basal cell carcinoma called pigmented basal cell carcinoma. And how do we know the difference? We take our dermatoscope and we look closely, and then we see the subtle changes there. And then as dermatologists, we can say this is probably basal cell carcinoma, not melanoma. But many times even we are confused even after dermoscopy. So of course, if we're suspecting cancer, we have to remove it. And then we send it to the lab, and the pathologist will be able to tell us, yes, this is basal cell carcinoma, what you've removed is enough. Or no, this is melanoma, you have to go back and remove a bigger margin and send them for testing, blah, blah, blah. Because with basal cell carcinoma, normally the treatment is just cut it out with a 5 millimeter margin, and it's out, and make sure it's out. With melanoma, it's different. So it's completely different. It's a more aggressive cancer. It can spread, it can kill, it can go to the lymph nodes. So there's a protocol that needs to be followed depending on the depth. We might need to, send them to check their lymph nodes, to have CT scans, to have loads of more testing, and then a bigger margin must be removed around it.
Yeah, but it can leave some nasty scars, can't it? I've now completely forgotten what I was going to say about that, because I have the brain of a gnat at the moment. If we've got the basal cell carcinoma and apart from the fact that it may feel, it might bleed or whatever, if they don't do that, should people be worried? How long can you actually sit with them happily? They're just slowly growing.
So you mean basal cell?
Yeah.
So in the NHS, in the hospitals, so the pathway is, and I'll tell you why, to answer your question, why I'm telling you about the pathway. If a GP suspects, if you're going through the NHS, of course, if you're going privately, any time you suspect something, you can take an appointment, go to a dermatologist, have it checked. But if you're going through the normal route, if the GP suspects this might be skin cancer, he'll refer you to the hospital to have it checked. If the GP suspects it's melanoma or squamous cell carcinoma, he'll put you on the 2-week wait list because you have to rush. So within 2 weeks, you get seen. If it's a basal cell carcinoma, the wait is longer because it's okay to wait on basal cell carcinomas until they have time. Of course, they're not going to make you wait 6 months or a year like with the other dermatology conditions. Now the wait is 1 year. But you can be seen within a month or two, it's fine. And then the dermatologist, if in the hospital, if they suspect melanoma or squamous cell carcinoma, they keep you on the 2-week wait. So it has to be removed within 2 weeks. A basal cell carcinoma can wait a few months before it's removed until they have the vacancy to remove it. So it's okay to wait a few months on basal cell carcinoma. It normally just grows locally, but it can grow to significant proportions. It can be nasty. And then it depends on the type of the basal cell carcinoma. It can be a superficial basal cell carcinoma that is just looks like a rash, and that can be treated topically with chemotherapy creams. It can be locally like a nodular basal cell carcinoma, so it's just a small lump. But there are types that are more aggressive, like the morphaic or the infiltrative basal cell carcinomas. And these are more aggressive. They grow faster and they infiltrate. They're not localized to one area. So removing them might require a more complicated surgery called Mohs surgery. So also it depends on the type. But if we're talking about skin cancer types, basal cell carcinoma is extremely unlikely to spread or to kill you, but it can locally grow. So it has to be removed. And it can invade deeper structures.
I remember what I was going to ask you, and this is an important one because, you know, we have a proliferation of people doing aesthetics these days who have machines that they can take moles off. You know, they have the plexer or they have a laser machine, but they're not trained in identifying what is or isn't a dangerous mole. So should people, if they want to go to somebody and have these moles removed, have them checked first?
Yes, absolutely. I have the machine. I have the laser. It's used for, you know, anything dark. So like the sunspots, freckles, tattoos, birthmarks, and it can also zap away moles. But this is extremely dangerous. A melanoma can start as a tiny little brown dot, and if you go zap that without having it checked by dermatologists, and I check all the moles and I make sure, and I will only laser moles which are extremely tiny and which I have checked with my dermatoscope and made sure 200% that there is they're not suspicious. And I've been a dermatologist for 25 years. So even for me, if I'm suspicious, I will not treat it. But if they go and have anything brown that lasered, they might be lasering a mole that should not be lasered, or they can be lasering, you know, if it's just a brown spot that just appeared, who knows? It can be a growing melanoma. It has to be checked, observed, photos taken, dermoscopy done to make sure it's nothing serious. And the other thing is the congenital moles, the birthmarks. The people are born with large moles. They can be small, very small, medium, and large. And sometimes they cover the whole trunk or the whole arm or the whole side of the face. These should not be treated with lasers because they're very thick and they have a risk of developing melanoma. So if you laser them, you're removing the pigment from the surface, but you're keeping the cells internally. So then if a melanoma develops, you can't see it anymore.
That's interesting. I did not know that. The other thing that's important when you mentioned having an annual check, I mean, I can tell you now, getting an annual check, even with my history, is incredibly difficult. But the other thing too I found here is to get all parts of your body checked is extremely difficult. I have to request, can you look at my scalp? I have to, can you look at my breasts? can you look at my bottom? Can you look in between my fingers and toes? And
Yeah.
because in Australia they are very thorough, they leave no stone unturned. Whereas here there seems to be a little bit sort of like, oh no, we don't touch the private parts because the sun doesn't shine there, so there's no risk. And that's not true. So there's no risk, and that's not true.
That's not true. Every single aspect of the skin has to be checked: ears, scalp, neck, between the toes. So all the time I tell them, remove your socks. I need to see in between your toes, nails, genital areas. Every inch of the skin has to be checked, because yes, you can get melanoma in private parts. You can get it between the toes, and you can miss it. Or especially melanoma, because it can happen in some protected areas as well.
Yeah. Will I show the melanomas?
Yeah.
Why not? We can move on to those. They're so we have this sort of A, B, C, D, E kind of rule, don't we? I mean, are they always as nasty looking as this? I mean, you said they sort of start off with a small thing, I guess, sort of like this one down here on the bottom. But can they look a little bit more benign than that in the beginning, so you may not notice?
Yes, and they can even be pink. And the most dangerous melanomas are the non-pigmented melanomas. They might not even have pigment in them. And even for us, they might be tricky, because if I see a pink pimple, if you want to call it pimple, and I cannot, and the patient says it has grown, it wasn't there, it's growing, it has to be removed because it can be melanoma. So even if I cannot 100% say it's melanoma, but it's a pink nodule, it might have some abnormal vessels. It might be an amelanotic melanoma, meaning a melanoma with no color. It can look very benign. It can look like pink spot. Yeah, can look like.
It's hard really to tell the difference between that and a squamous cell carcinoma, really, isn't it? They're kind of similar, and this could easily be a basal cell carcinoma.
Yeah.
Very tricky.
Yeah, it's difficult to
have a
tell.
tough
That's
job.
why when we're suspicious, we remove it, send it, have it analyzed. It's better.
Yeah. Yeah.
Amelanotic melanoma is difficult. Yes, it is tough. And yeah, they can start small and then grow. So, and the other thing is with people who have a lot of moles. So some people have a lot of moles. And especially if they're abnormal moles, dysplastic moles, and they run in families. So these people have a higher risk of developing melanoma, but it does not necessarily have to happen in a mole. Most often it does not happen in the mole itself. It grows on, normal appearing skin. So having a lot of moles, having fair skin, blue eyes, having been in the sun a lot, having had sunburns, having a family history of skin cancer, being on treatment that reduces your immunity for any other reason, all of these increase and being in sunbeds, that's the most important. These will all raise your risk dramatically.
There you go. I think I've got 8 out of 10 of those, or however many there were. Very, very difficult. So,
yeah,
what do we do? Prevention.
Yeah.
What do we do?
Sunscreens here, I wanted to show them. So the sunscreen should say UVB, UVA, and visible. So now these sunscreens have to be broad range. Although UVB, ultraviolet B, is the one that mostly causes skin cancer, UVA is more involved in aging and wrinkles. So if you want to have no skin cancer and no aging, use a combination sunscreen. And of course, all the new best sunscreens are a combination, even visible light. So avoid sun exposure, wear sunscreen every single day, even if it's rainy, cloudy. When you're in the sun, wear a wide brimmed hat, wear sunglasses. This way you protect your eyelids as well. Do not be in the sun from when the sun is in its peak, 11 to 3. Go indoors. Seek shade as much as you can. So don't sit and bake in the sun. And I hope my own daughters are listening to me right now. Do not bake in the sun. No tan is healthy. there is no healthy tan. So, you know, that glow and tan you get, okay, you can tan very gradually, and that gives you some protection. But with every tan, you're damaging your DNA. But the most serious thing is the burn, the actual burn, because that damages the DNA. You know, to the highest extent. If you do it very gradually, that is better.
Bake it, don't bake it is your
Yes.
message.
And then if you get anything that you're suspicious of, any growth that you're not sure of, any rough spot on your legs, on your face, anywhere, any bump, any acne spot that keeps bleeding, have it checked, because the earlier skin cancer, and specifically melanoma, is removed, the higher the chance of survival and preventing metastasis.
Yeah, they've got some quite new and interesting types of treatments though now, haven't they? The vaccine that they're developing, which is kind of interesting.
They are new treatments for melanoma and advanced squamous cell and basal cell carcinoma. There's always the chemotherapy, the radiotherapy, and then there are new treatments for advanced basal cell carcinomas. We call them the hedgehog inhibitors. They're medications that are very expensive. They have to be in specialized centers. They're not available in pharmacies. And there's the immunotherapy for metastatic squamous cell carcinoma and melanoma. Again, that's I don't do that. This is oncologists in hospitals who do these things. So the treatment is advancing, but early detection and early removal is the key to prevent people from needing those treatments.
Yeah, and the other thing, I guess, is the other thing that's actually kind of interesting is there's a bit of evidence now for using niacinamide or nicotinamide topically to help prevent or reduce sun damage. Is this something that people should think about?
I haven't heard of it, but the topical thing and even the oral thing that can reduce and prevent is are the retinoids, the tretinoin. That can reduce, it can actually reverse early mutations, DNA damage, and even orally it can help treat precancerous lesions, but I haven't heard of niacinamide.
Really, that's interesting. Actually, so then you would think that somebody would say to me, Fiona, you're an idiot. You should have some tretinoin because your whole body is just one giant walking potential actinic keratosis, squamous cell carcinoma. If it's something that is topical and easy to put on, wouldn't you think that people would say prevention's better than cure? Take this tube of cream and slather it on?
I didn't get your question.
So would it not be sensible for people who are at high risk like me to be given something like tretinoin then to put on?
Yeah,
because it would be sensible.
Yeah, it's the best thing you can do, right? So it can reverse, and like I said, even orally it can be used to treat, and it's not as, you know, it will not treat them as much as a 5-FU or the other treatments, but it's helpful. If you're telling me what topical can I use to prevent and treat very early, I have to say it's the retinoids, the tretinoin.
Yeah, well, there you go. Now that I did not know. The other thing, I guess, I suppose, on the vanity side, things that might actually make people not stay in the sun, is the changes in pigmentation that you know, the sun damaged spots that you can see all over me as well, the spots, the dark spots from the sun. So what can be done when people have developed those? What do you do for those?
So sunspots, which are like, they look like freckles, they're a sign of sun damage. I treat them with lasers. So I have the Q-switch laser, which can zap each and every one of them. We can do the CO2 laser or a chemical peel all over the face. That can also, or face or body, it doesn't have to be face. And that can erase the whole area and treat the whole area. If they have developed pigmentation in the form of melasma, not as in sunspots or sun, freckles. If it's melasma, then I don't use lasers. I would put them on creams, and I can do chemical peels to remove or pills, tablets sometimes, to treat the pigmentation that has happened. Most often, the sun-induced photo damage is in the form of sunspots on the hands, on the face, blotchy pigmentation, and that can be treated. Yes, laser. You know, I love my lasers. I have so many tools. So I have one laser that does, you know, different things. So that will be the Q switch laser, which will zap them.
Yeah.
And it will peel off within a week. Normally, one session is enough.
Yeah. Over time, though, do they come back and people do things to sort of maintain, to sort of keep them at bay during a period of time?
The one that's removed will not come back. And if we're treating sun damage that has happened over decades, it's unlikely that they will pop new ones. But if we're treating it at a young age and they're still getting exposed to the sun, yes, they will get new ones, if you know what I mean. But the one that's removed does not come back.
Yeah. And the other thing, I guess, is I'm now looking for one of them on me as well, is where the pigmentation disappears.
Gone. There's no treatment for that. That's called idiopathic gut-tape hypomelanosis. It's a big term, but it's sun-induced, and there's no treatment, unfortunately. So you have to live with it.
Yep. There are many things that we have to live with. Some of them can be avoided. If you, yes, exactly. So you know, don't do what I do. Do what I say.
I have a lot of that's at the clinic that then they can pick and take with them and read. That all discuss how you should avoid the sun and what it does to you. So I love these things and I give them away for free.
I guess, you know, there are people who are like me, recidivistically stupid, and of course I am going to Ibiza for my holiday. But I do have a big hat. I will be wearing my SPF 50, and I do now, instead of lying in the sun, seek shade. I just sort of go out to swim and then come back into the shade. For people like me who just can't help themselves, what can we do?
Wear protective clothing. So there is UV protective swimwear, which you can swim with. And this will, you know, give you better protection because you like to be in the sun. You're wearing your sunscreen, at least cover your body. Wear UV protective swimwear, and they're very common in Australia. And they can even be long sleeves. You know, you don't have to go that far, but at least cover this part by wearing a swimming t-shirt instead of a swimsuit. So the less the sun is exposed, skin is exposed to the sun, the better it is. So even in the shade, you still get UVB and UVA going into the shade. So it's not, you can get burned in the shade. So wear a t-shirt, cover yourself as much as you can.
Yeah. There you go. Is there anything else that we need to think about in this? If people are interested, if people want to know more, are you doing skin checks and stuff, or you're still doing them, aren't you?
Oh yes, people come to me all the time for skin checks, and we do like a full mole check, full mole screening. If they've had a skin cancer in the past, they come and we do a thorough check. If they've had actinic keratosis, they come back and I, you know, zap the new ones because you can, you know, better you can get new actinic keratosis as time goes.
Yes, I've just had 8 of them zapped off from various different parts of my body, not just the face, but across my back and on the legs, and just it's like, oh God, is this ever going to end? But I only have myself to blame. So there you go. I cannot blame anybody else but me.
And the sun in Australia.
Yeah. Let's blame the sun. Yeah. Brilliant. All right. So you are, if people need to find you, you are Dermasurge. You're on Harley Street, and is there any other place they can find you?
No, just here.